Good evening, everyone. This brings us to the tail end of the translation session, and I'll be doing the second rapid review. There are a couple of interesting abstracts on circulating DNA and their use in a prognostic and predictive settings, and also a couple of other interesting abstracts as well. So, the first abstract is on plasma cell free DNA integrity, which predicts the achievement of PAT-CR to neoadjuvant chemo in breast cancer patients. This was presented at the AACR annual meeting last year. And the background of the study is that plasma free cell free DNA integrity, or DI, has shown potential for providing useful information. And the aim of this study is to estimate the accuracy of an electrophoretic method for DI assessment and evaluation of response of patients undergoing neoadjuvant therapy. 62 patients underwent anthraxane based chemotherapy. Plasma samples were collected at 3 time points: at diagnosis, post-anthrax chemo, and pre-surgery. And after the cell-free DNA extraction, fragmentation profiling, or DFP, was performed for each sample. The concentration of differently sized DNA fragments was assessed, and cell-free DNA fragments were evaluated. They took the most informative of the response to neoadjuvant. These were selected, and then they calculated what was known as a cell-free DNA integrity index, or DII. A classifier was then developed, and its performance was directly compared with MRI. DI showed an overall accuracy in correctly predicting the achievement of PAT-CR of 81.6 versus MRI of 77.1. And although the specificity was same in both these modalities, the sensitivity for DI was far superior. The performance of the two techniques combined in case of concordance achieved an accuracy of 92%. So DI measured before surgery and after completion of neoadjuvant therapy does show great potential to predict the achievement of PAT-CR and certainly needs to be further investigated. The second abstract was a very interesting one. It was actually the usefulness of assessment of circulating DNA of CSF samples for early detection of brain mets with triple negative breast cancer, having huge therapeutic implications. This was published in the Journal of Clinical Oncology last year. And the problem was that there were questions that arose with the integrity of the method's results and analysis. And this abstract was later retracted and is right now still undergoing review. The third abstract is serial circulating tumor DNA samples from patients with metastatic breast cancer and BRCA1 or 2 mutations, again from ASCO last year. Analysis of ctDNA over time allows a very nice non-invasive evaluation of the genomic evolution of the tumor and changes in the tumor fraction, somatic copy number alterations, and somatic mutations with BRCA1, BRCA2 mutations and metastatic breast cancer in patients who had received a PARP inhibitor or platinum therapy were characterized. And what one was looking for was the frequency of BRCA1 and 2 reversion mutations, which we know is an indication of PARP inhibitor resistance. So patients with metastatic breast cancer and germline or somatic BRCA mutations were identified. This was prospectively done on samples of blood and plasma, and there were control patients as well without BRCA mutations. This was matched 2:1. And whole genome sequencing was performed on all the plasma samples, 103, the tumor fractionations, and the CNAs were determined. Targeted panel sequencing, or TPS, of 402 cancer-related genes was performed. This included BRCA1, BRCA2, and 38 other DNA damage repair genes. Somatic mutations were also identified. Coming to the results, 10 patients with metastatic breast cancer had a germline or somatic BRCA or BRCA1 or 2 mutation. The control cohort were the wild type, and germline mutations were confirmed in all 7 patients with such a known status. The results further showed that a median of 1.5 somatic mutations per patient were found in the DNA damage repair genes. 4 patients had secondary non-reversion mutations. One reversion mutation of a germline BRCA2 patient, which restored the open reading frame, was discovered at the last time point while receiving carboplatin, and there was no significant difference in the percentage of genome with CNAs between the first and last time point. In conclusion, evaluation of serial ctDNA samples is feasible in metastatic breast cancer. The frequency of reversion mutations in BRCA1 and 2 is low, suggesting either the incidence is truly low or that the TPS is not sensitive enough to detect them. Secondary non-reversion mutations in BRCA and other somatic DDR mutations are more common, and the CNAs are stable over time. The fourth abstract is the CTRAC study. So primary results were presented from this hypothesis generating study. This is a clinical trial utilizing circulating DNA mutation tracking to detect MRD or minimum residual disease and trigger some sort of intervention in patients with early stage triple negative breast cancer who are at a high risk for relapse. This was presented by Turner and his colleagues at SABCS last year. This is a multi-phase 2 pilot trial looking at the prospective use of ctDNA assays in this group of patients. So what they did first is after the treatment was completed, the surgery and adjuvant chemo, the tumors of each patient were sequenced, a personalized ctDNA assay was prepared, and 1 to 2 mutations per patient were tracked further. Once the ctDNA was detected as positive, patients were further randomized 2:1 into the intervention arm with pembrolizumab given for a year, and the ctDNA was measured monthly for 12 months, and the other arm was the observation arm with no intervention. They plan to register 200 patients. They also assume 30% would be ctDNA positive within a year and 20% would be detected on scans with the ctDNA positivity. The treatment group versus observation were not powered for formal comparison, so we don't have any outcome endpoints, but the co-primary endpoints were the rates of ctDNA detection at 12 or 24 months from start of pembro and how the patient cleared the ctDNA on pembro or recurrent 6 months after pembro. So 200 patients were registered, high risk and moderate risk, 171 had trackable mutations, 161 continued to ctDNA surveillance, 108 had 1 and 53 had 2 mutations tracked. The median follow-up was 20.4 months. All of them completed active surveillance. The proportion of ctDNA positivity by 1 year was 27.3%. Remember, they had anticipated 30%, and more so in the high-risk group at 55%. 7 patients relapsed without prior ctDNA detection. If you look at the therapeutic trial, very few came up for therapy. So 32 ultimately ended up in the treatment group. And here you can see in the high risk group, only 4 commenced treatment and 1 is still on treatment, 3 discontinued. In the moderate risk group, only 1 commenced treatment and this patient also discontinued. After commencing pembro, no patients exhibited sustained ctDNA clearance, but the numbers are really too small. In the observation group, the lead time before scans was 4.5 months and 1 month, and 21% remained recurrence-free. All of these were able to clear the ctDNA. So this is the first trial to assess the proof of principle whether ctDNAs have clinical utility in guiding further treatment in TNBC. And we had a lot of relatively high rate of undiagnosed metastatic disease when imaging took place, and few patients commenced the pembrolizumab treatment, so we don't know the activity of this agent in this setting. The fifth abstract is circulating DNA dynamics in patients with hormone receptor positive advanced breast cancer treated in first line with ribo and letrozole in this trial. And this was again presented at San Antonio last year. So there are no biomarkers as such to predict the response to CDK4/6 inhibitors, and we've been searching for a long time for markers of response and resistance. ctDNA analysis is emerging as an attractive non-invasive approach, and the impact of baseline and dynamic monitoring with ctDNA analysis in these patients was assessed in this study. So this was the study design. 287 postmenopausal women were taken up for the study, and they had a treatment-free interval of more than or equal to 12 months. The timing of the liquid biopsy was at baseline, at day 15, at cycle 2, day 1, and at the time of the first imaging, which was at 3 months. And the primary objective was to identify ctDNA alterations and their possible association with clinical outcome. The presence of ctDNA at baseline appears to be a negative prognostic factor from the results. Among patients who had a detectable mutation at baseline, treatment led to clearance in 50% of the patients, and this happened as early as 2 weeks, suggesting that it has a predictive value. No appearance of detectable mutations after baseline was associated with a lower risk of progression. That means it's a bad thing to acquire these mutations during treatment. And overall, both pre-treatment and early dynamics of ctDNA can represent a promising predictive biomarker in patients treated with ribo-letro, and certainly further studies are warranted to further demonstrate the clinical utility of these biomarkers. The sixth abstract is very interesting and deals with the theme of overcoming endocrine resistance again. This is about dual mechanism estrogen receptor inhibitors, and it involves quite some biochemistry as well. So all SERMs, as we know, they contain an additional aromatic ring, which is called the E ring, attached to an amino-alkyl side chain exiting from the ligand binding pocket where the estrogen actually combines. This side chain then controls the antagonistic activity of breast cancer growth, as well as selective modulation of ER in other target tissues. Fulvestrant contains an extended sulfonyl side chain, and the new oral SERDs like giredestrant and elacestrant that we've heard so much about have an acrylate one. What was different is this group of investigators studied a different approach. In addition to the side chains, which are responsible for what we call the direct antagonism that we see, bulky chemical groups are attached within the ligand binding pocket, and they actually distort the epitope, and this leads to indirect antagonism. This new compound, which they labeled as compound 19, actually inhibits MCF7 cells with greater efficacy than tamoxifen or fulvestrant. So to address the unmet need for effectively suppressing estrogen receptor with both de novo and acquired resistance to endocrine therapy, the authors and the investigators developed a dual mechanism of ER inhibitors, the DMERIs, which employ two distinct ER targeting moieties, and they're able to generate highly efficacious antagonism of proliferation in the ER positive cancer cells. And we need to look forward to the development of these agents in clinic in future. The seventh abstract is on CCN1 mRNA and cyclin E1 protein expression as predictive biomarkers for efficacy of palbo and fulvestrant versus capecitabine from the PEARL study. And this was presented in ASCO last year. So CCN1 and cyclin E1 expression as predictive biomarkers were explored. CCN1 was measured with a biomarker panel, which mRNA expression containing over 2,500 genes, and cyclin E1 was measured by IHC. 219 patients were analyzed, and both were only moderately related with each other. Coming to the results, median CCN1 was higher in metastatic versus primary tumors and in luminal B and non-luminal subtypes compared to luminal A. Median cyclin E1 protein was also higher in luminal B and non-luminal versus luminal A. In those patients which showed and demonstrated a higher CCN1 expression, 110, the median PFS on capecitabine was 10.5 months versus 5.68 months on palbo and fulvestrant with an adjusted hazard ratio of 1.63. In patients with a low expression, there was no difference between the PFS between the capecitabine and the fulvestrant and palbo groups. Cyclin E1 levels were not predictive of treatment benefit. Therefore, high CCN1 mRNA expression can identify patients with relative resistance to fulvestrant palbo combination, and this has validated prior observations from the Paloma 3 study. Cyclin E1 protein expression does not show such a predictive value. And we need better treatments which will explore this hypothesis to enhance CDK4/6 inhibitor efficiency in patients with higher CCN1 expression. Eighth abstract shows the prospective longitudinal multi-omic study of palbociclib resistance in hormone receptor positive metastatic breast cancer. This is from ASCO last year. The objective of this study was to identify biomarkers of palbo resistance to assess molecular changes during treatment and at disease progression. So 71 patients with ER positive MBC underwent biopsy at baseline during treatment, and 33 patients underwent it at progression. Longitudinal biopsy samples were collected. They were subjected to IHC, RNA-seq, whole exome sequencing, and they looked at somatic mutations, copy number alterations, HRD genomic scars, gene expression, etc. Coming to the results, an unsupervised analysis of the genomic scar features actually identified a HRD high cluster. And this cluster was found to be significantly enriched in BRCA1 and 2 mutations and a luminal subtype. And patients with this high cluster had a worse PFS compared to the HRD low cluster. Also, patients with a baseline TP53 mutation and combined TP53 and BRCA mutations also showed a worse PFS compared to patients without these mutations. Frequent switching of intrinsic subtype during treatment was seen. At disease progression, many luminal A's had switched to luminal B's and HER2-enriched subtypes. So the longitudinal multi-omic study did identify prognostic biomarkers as well as post-treatment enrichment of HRD-related genomic scars and frequent subtype switching into those with aggressive and estrogen-independent characteristic. And this is something which we should be and will be doing in the clinic very soon. The last abstract talks about tamoxifen, how it instigates uterine cancer development by activating PIK3CA signaling, and it supersedes a PIK3CA driver mutation. This was also presented at the San Antonio conference last year. So we know that tamoxifen use of 2 to 5 years is associated with an increased incidence of uterine cancer, almost 2.7-fold. The ATLAS study further confirmed this, and it showed a 2-fold increase above and beyond this after 10 years of tamoxifen use. The aim of this study was to identify the mechanism by which tamoxifen does induce this cancer and whether we can prevent it with any therapeutics. So 108 tamoxifen-associated uterine cancers were included from the Tamarisk study, and there was a discovery and validation cohort. 21 blocks from the discovery cohort had whole exome sequencing performed. 36 blocks were included for validation, and here hotspot mutations were performed. Coming to the results, they first determined that the molecular subtypes of these tamoxifen-associated uterine cancers were not different from the TCGA or the conventional uterine cancers, and fell in the 4 known molecular subtypes, that is the microsatellite MSI, the pole ultramutated, the genomic stable, and the chromosomal unstable. Whole exome sequencing was also established that the driver genes were not different, but what they found that there was much fewer PIK3CA driver mutations in the tamoxifen-associated uterine cancer, and this was validated with hotspot mutations in the PIK3CA group, and found again very few mutations were found compared to the TCGA cohort. They then hypothesized that maybe tamoxifen replaces the mutational activation of the PIK3CA pathway via the ER crosstalk by activating IGF-1. And can tamoxifen activate this crosstalk? And can it be abrogated by PIK3CA inhibitors, was the question asked. So an in vivo mouse study was performed, and the groups of mice were subjected to placebo versus tamoxifen alone versus tamoxifen with alpelisib. And uterine tissue from mice showed that tamoxifen can actually increase PIK3CA signaling, which can then be abrogated with PIK3CA inhibitors. The uterine stroma from these mice showed an insignificant increase in IGF-1 concentrations by the tamoxifen, suggesting a paracrine effect. So these results offer new mechanisms of drug-related cancer development in which a drug activates a signaling pathway that substitutes for the selection of a driver mutation. Thank you for your attention, and I hope to see you tomorrow at the main conference, which will start at 4 p.m. sharp. Thanks again.